So our next panel will be moderated by David Holthouse. He's the managing editor for opinion and engagement at WCPO.com. And earlier we heard Sam talk about getting into more depth on a topic, and this group, WCPO.com, is one of examples in our community that's doing that. It's a digital newspaper housed at WCPO Channel 9, a Cincinnati television station. And among other innovations, David has assembled a heroin advisory board to guide the station's coverage and commentary on the opioid crisis. So please help me welcome David Holthouse.
Thank you. Good afternoon. My name is Dave Holthouse, and what I do at WCPO TV and WCPO.com, one of the things I do is lead our editorial board process and write editorials and manage that process. We're one of the few, if perhaps the only TV station that editorializes on a regular basis, and we do that largely on our website. But one of the big projects we've had, as Gail mentioned, is we've been doing for a couple years now is how should we as a community respond to the heroin epidemic. And Sam mentioned the needle in your arm story. We've all seen plenty of those. We get that there's a problem. Our focus has been what should we do as a problem. So we've put together a resource online, and WCPO.com/heroin, and there's a series of editorials, op-eds from contributors, investigative stories, and so on that's gathered there and collected there as we feel as a community resource. And some of the folks here today have worked with us on this advisory group. Dr. Feinberg and Dr. Kalfas, Margot Spence here is with us, and some other folks that I've seen here today have worked with us on that, so I appreciate all their work. And I wanted to also thank NKU for hosting this and taking this first step in what I hope is a continuing effort to bring the research expertise together. So let me introduce the panel. On my immediate right here is Margot Spence. She is the President and CEO of First Step Home. It provides treatment for women with substance use disorders in Cincinnati, residential outpatient and maternal addiction programs. She directs the community awareness functions for the agency, oversees fundraising, the budget, provides board leadership, community relations. First Step also provides safe and sober housing for recovering women and their children up to the age of 12. And they have a campus here in Cincinnati of 12 buildings where they do that. Next to her is Danielle Matthew with the Baby Steps program. She started her nursing career in the year 2000 at St. Elizabeth's in labor and delivery. She's worked in ICU and in the surgery center. She said she's drawn back to her love of mothers and babies and has worked as the assistant nurse manager of labor and delivery until this position became available at the Baby Steps program. She says if just one woman is spared from this terrible disease of addiction, gets sober and lives a life in recovery, a life has forever been changed. Next to Danielle is Lisa Jason. She is a neonatal nurse practitioner who works at Dayton Children's Hospital and a doctor of nursing practice, and is the clinical director of Bridgets Path. She directs the neonatal nurse practitioner program at Wright State University and has been working on the neonatal abstinence syndrome issue for a number of years, and she's excited about starting a new facility to care for infants and families affected by substance use. So we'll start with Margot.
Thank you, David, for all the work that you do helping to get the information and the awareness out of what we're trying to do in our community. Good afternoon. It is a pleasure to be here, and I feel that I'm not here by myself. There are many partners out here that are on the front lines of helping women and babies that are in need. I have a team here, actually. I have Jean Cole, who is the coordinator of the Maternal Addiction Program, and also our medical director, Dr. Mark Hott. So any really difficult questions, I am going to hand over the hot potato to them. As an executive director, as a president of an organization, I spend most of my time in Columbus talking to legislators, trying to raise money for our agency and those kinds of things. So they are the superstars that actually work with the clients and develop programs and so forth. This is our main site, and in order to really talk about our work with pregnant and postpartum parenting women, I have to tell you a little bit about our agency. This is a little bit about the history. We've actually been in business since 1993. A group of recovering women received numerous calls from women that wanted a safe environment to be able to bring their children into treatment with them. We did not, in the Hamilton County area, have any agency, drug and alcohol certified agency, that would allow children up to the age of 12 to come into treatment with them. So certainly that was a barrier for women going into treatment. To my knowledge, we're the only certified program in Hamilton County that allows women to this point to bring their children into treatment. All of the women that we have at First Step Home are addicted to drugs and or alcohol. At this particular point, probably 90% of our women are addicted to opiates. And that's been a major change because probably about 8 years ago or so, the majority of our women were addicted to crack cocaine, alcohol, marijuana. So we've seen a significant change in the drug as well as the socioeconomic backgrounds of our clients also. We have a daycare on campus, and over the years, we've served probably over 4,000 women. And we cannot do it alone. We have many partners. We work with Good Sam Hospital. We work very closely with CPS, Children's Protective Services, and also Children's Hospital and MAT providers in our community. This is a general profile of our clients. The average age is actually around 29 years of age. We provide a wide range of services. I heard one of the presenters earlier talk about transportation being a barrier, and we've made sure that we provide transportation so that our clients, pregnant, non-pregnant, parenting women, and so forth, are able to get to their appointments, the daycare there on campus, VOCAD services, because it's not just about abstaining from drugs and alcohol, but it's about providing a whole range of services for the women that come through our doors. For the clients that present at First Step Home, quite a few come from Good Sam Hospital, as well as some of the other hospitals, and also from the criminal justice system. We provide residential services. We have a 16-bed facility. We also have intensive outpatient services and regular outpatient services and a whole housing department. We have, as David mentioned, 12 houses on a city block. If you come to our street, you would think that they are just regular houses. So we're doing everything that we can that for pregnant women as well as single women feel comfortable in the environment that we are setting. So we have one treatment facility that provides 24 hours, 7-day-a-week supportive services. We have certified drug and alcohol counselors, social workers. We have a psychiatric nurse, medical director, a nurse that provides services, and so forth. Once a woman meets certain goals and objectives on her treatment plan, she's able to step down into one of the houses that we have on the city block as well. I'm going to share with you the MAT data, and please don't look at a lot of the numbers because we've been looking at this for weeks, and until we sat down at this table today, we saw some numbers that were off. So I don't want you to pay attention to a lot of the numbers, other than you will note that the majority of our women present late term. And we're trying to do everything that we can to get the message out that you will have better outcomes if you present as early in the pregnancy as possible. Many of the women are very, very worried that their babies are going to be taken. At First Step Home, we are working very closely with Jobs and Family Services so that we have a good understanding of the progress that a client is making so that we can hopefully reduce the chances of a child being removed from the mother's care just because of policies. You know, I think everybody realizes that there aren't enough foster care to take care of all the children that need assistance.
We had the pleasure of visiting First Step Home, and it was beautiful, and we really enjoyed the tour that we got. Thank you so much for inviting Baby Steps program to come here today. This is a great honor, and I'm really excited to be able to share what St. Elizabeth Baby Steps program is doing in the community. Sorry, I need the clicker. Hold on one second, sorry. There we go. Okay. So what Baby Steps is, we were started about 2.5 years ago. A nurse at St. Elizabeth identified that there was a need in the community for moms and children that were dealing with, mothers that were dealing with substance use, and they were just not getting or having the access to resources that they needed. So she actually went to St. Elizabeth to some of the administrators and said, this is a need, what can we do about it? And they stepped up and said, you know, what do you think that we need? And a program was started. And through that program, it grew. And St. Elizabeth received a grant, and they were able to hire 2 nurses, one of which was myself and my the other nurse that I work with, Andrea, that's here with me today. And then since then, that nurse has moved on, so Andrea and I are here, and we've expanded. We have another nurse that is a community health nurse, and then even in the near future, we're expanding further to have more staff. We're going to have 2 peer support specialists that will be working with the clients. They are actually women that will have 2 to 5 years of recovery time, and they go through a program, they get certified, and they'll work with them one-on-one. And then we're also going to get some clerical support too, which we are very excited about. So that's kind of where we are as a program right now. Who we provide services to, we provide services to pregnant and parenting women that are dealing with substance use disorder. Our program focuses on, the grant focuses on opiates. However, we get referrals for women that are dealing with any substance, and we do not turn anyone away. That is just what our main focus is. Women are referred to our program through numerous sources, their OB provider, self-referrals, families, friends, Child Protective Services, social work, and the newest way is through the EPIC system, which is a computer system through St. Elizabeth. If a mom has a pregnancy diagnosis and they have a positive urine drug screen, so through any service that they're receiving, if they come in through the emergency room, through their physician's office, and that diagnosis is given, that positive urine drug screen, we get a referral on that mom. So as an example, we have a mom just recently that was referred to us at 8 weeks in her pregnancy. So we are getting early intervention. We are identifying these moms. That was the earliest one, and that's just been of recent. Before that, it was 11 weeks. But we are getting these moms identified early and referred to us. And so at that time, we contact that mom. We reach out to her. We see where she's at, what's going on, and just work with her from there. The woman receives services wherever she's at, whatever stage she's at, and whatever she's facing in her life. We walk alongside the woman throughout the whole process, and we follow her up until 2 years after delivery. And then sometimes, we do have some women that are pregnant. We have worked with, they deliver, and then, of course, sometimes become pregnant again, and we'll work with them through the second pregnancy as well. Where do we go? We go anywhere. We meet moms at Frisch's. We meet moms in parking lots. We meet them pretty much wherever they are, whatever is convenient for them. As we've heard mentioned numerous times today, transportation is a huge barrier. We do have, however, through our grant, bus passes, things like that to offer to our clients that we can help them with. So we, once meeting with them and assessing them, and if that's something that they need, we can help provide that for them. But the program provides evidence-based parenting classes to the women in Campbell and Kenton County Jail. I provide Campbell, and Andrea goes to Kenton County Jail. We also provide the Hazelton Betty Ford Core 12 education to the women at the Transitions WRAP facility. So we work very closely with them. We refer our pregnant moms to residential treatment at Transitions WRAP facility. So if we need to get someone in, we can call them and we can get a mom in there the same day. So we have a great working relationship with them. We are home visiting nurse. She goes to the women's homes. She does education with them in their homes. She does assessments. We can kind of do an assessment and see, what CPS might be looking at when they're going to come in and help work with them. We do NAS education, and we work with them as far as medication-assisted treatment. And then I think that was all of that. And then we do, as I said, the parenting classes. That's what we do inside the jail and with the moms at their homes. And then the next slide is just our brochure, and I know you guys are going to be in the slides, so our program information is on there. And we're available 24 hours a day, 7 days a week. Thank you.
Okay, my goal was to point the remote in the right direction. I've achieved my goal for the day. So I'm Lisa Jason. I am a nurse practitioner at Dayton Children's Hospital and the clinical director for Bridgets Path. And this is Bridgets Path. This is our facility in Kettering, Ohio, and it is right on the corner of the street that divides Kettering and Moraine. So we are in the Dayton area. Who do we care for? In my opinion, we care for patients that need to be the priority in their unit. so many times in level 3 NICUs, and I have talked to multiple nurses and multiple physicians about the care of our NAS babies. And there's a little disconnect there. We all say we're doing something, and then reality sets in. And I spoke to a nurse the other day who told me it was probably not the safest situation, but I had to keep this baby's CPAP in, and my other baby would not stop crying unless I rocked him in his stroller. So I set the stroller outside the door and had my foot on the stroller, moving the stroller while I maintained the CPAP, because our staffing wasn't good enough that I could find someone else to help with the NAS baby. And I said, I'm going to share your story with the people I'm talking to Friday, because that is why we're doing what we're doing. So we're going to treat the baby. We want to support mothers and other caregivers. So that includes the fathers, the extended family, foster family, whoever's taking care of the baby. Our goal initially, because we are outside of the hospital inpatient care for our babies that are being medically treated with methadone or morphine for neonatal abstinence syndrome, or NOWS, we want them to be 37 weeks of gestational age. We're beginning to take babies at the end of this month, and we want to make sure we've set ourselves up for success. And I loved the mortality rate of 0. That made me very happy, because I don't want to be a headline. We want babies that are stable, no comorbidities. We want them only under medication treatment for neonatal abstinence syndrome, and we want them at the point where they're beginning the weaning process. And part of that is, again, set ourselves up for success, but build outcomes in the community so that we develop trust with the people that we're working with and who are referring babies to us, most of whom we know and who know that we provide good care. But still, when you try something new, you really need to set yourself up for success. Our focus is really on non-pharmacologic management, and I don't think I need to go through this. We all know what it is, but I'm starting to get phone calls and emails. Are you interested in us coming to do infant massage? One of our neonatologists in the area, who was completely against this in the beginning because he felt like these babies needed to be in the level 3 NICU, just sent me an article about acupuncture and the treatment of NAS. And he said, this sounds like a great idea for your place. And I thought, okay, we're onboarding people, if not physically, emotionally. And you know, we've had somebody offer aromatherapy and music therapy, so people are coming out of the woodwork to support us. One of the things that we're basing our care on is strengths-based family advocacy, and as we've heard all day today, meeting the parents where they are. And one of the things that I can't share with the moms that are coming in, the mothers of these babies, is that lived experience. I've never been addicted to anything. Like Sam said, I'm high on my job. I get up every morning and I'm so excited to go to work. Granted, I don't like to get up until 9 or 10, but even at 5 a.m. this morning, I was excited to get up and drive here. But we wanted to make sure that we had a living space where our moms could come together and where people that had the same shared lived experience could support each other. So if we've got a mom that's in treatment, her words are going to carry a whole lot more weight to a mom that's not yet in treatment than my words ever can, because I just haven't lived that. I've never had to seek treatment for addiction. But that kind of support, instead of keeping our moms apart, letting our moms come together and have that community and share the experiences that they've had, we're hoping is going to work out better for both of them. Give our moms that are in treatment somebody that's looking up to them, and maybe boost a little bit of their self-confidence as well. So what you can see here is the living room area of one of our pods. We have 24 rooms, and they're divided into 4 6-nursery pods. And there's a living room just like this with a bath, an area for bathing, areas for diaper changing, and then the 6 nurseries. And I have a picture of the nursery later on. Our primary medication is methadone. That's what's used in the 3 nurseries that our medical director, Steve Hunter, works in, and the nursery that I work in with him. So we opted to stay with what we know for the beginning, not thinking that that's where we're going to stay and be narrow-minded about it, but we need to start somewhere. And our secondary medication is going to be phenobarbital, although we don't use it very much. And hopefully, fingers crossed, with our focus on non-pharmacologic management and non-judgmental care and support of the moms, we're not going to need much in the way of adjunct medications. But there's always that possibility. So here's one of our nurseries. We are not residential for moms at this time. We're licensed by the Ohio Department of Job and Family Services as a children's crisis care center. And as Mary Taylor had alluded to earlier, it was somewhat of a struggle to get us licensed as anything in the state of Ohio. So we're taking what we can get and we're running with it because we're the first of our kind in our state. Every nursery has a crib. Every nursery has a dresser, a rocking chair, lights with blinds so we can make it quite dark in the room, a door that's glass so we can always see in. All the babies will be monitored if they are not attended. And these 6 nurseries surround that living room area that you saw. We have, like I said, a strengths-based family advocacy focus, and we have specially trained family advocates to meet with our mom before the baby's admitted, during admission, and then after. And we'll be following up the babies for a year at 3, 6, and 12 months after they go home, looking at what's happening with their follow-up visits. How is the baby growing? Are they making it to their PCP appointments? They'll be referred to a regular developmental clinic. And then finding out what's been going on with them. Are they still with the person that they went home with? Did they go home in foster care and now they're with mom? Our family advocates are going to help with substance abuse treatment. We are not providing substance abuse treatment to the moms in our facility at this time, but there are partner agencies in the Dayton area that we'll be working with. And then they'll provide counseling and help with housing, food, and transportation, because I'm not going to beat the dead horse of if a mom's food insecure, housing insecure, how does she focus on recovery? As far as our metrics, we all want to know about outcomes, and I don't have outcomes to share with you yet because we haven't been open yet. However, I did talk to Susan Ford from OPQC. Hi, Susan. And thank you so much to the Ohio Perinatal Quality Collaborative for all the work that they have done over the years, setting us up with the information that we need and data collection tools to help us follow outcomes for our babies. So we're going to add to their OPQC sustain phase that they're in. We'll look at our length of stay and length of treatment. And what's most important to me is total exposure to opioids after birth. And if there's a way to get that down, I am all in for that. We want to look at our breastfeeding rates, and we've got a couple nurses that really focus on breastfeeding that we've just hired. So I'm really hoping that we can get our breastfeeding rates up a little bit higher than what I typically see them in my home nursery. We want to relate our Finnegan scores to our non-pharmacologic care and know who's providing the non-pharmacologic care. So that's something that the nurses are going to be documenting, and then we're going to be following. And then, of course, our disposition placement. Who are they going home with? One of the things about Bridgets Path that's very special to me is if there's an opportunity for a parent or for a baby to go home with a family member and not into non-kinship foster care, and the kiddos need to stay with us for a little bit longer so that home studies can be done, so legal things can be done, that's an opportunity they have at Bridgets Path that sometimes they don't have in the hospital because there's a little bit more pressure to get babies out. So if we need to do some social holds, we can do that for a limited period of time. So how did it start? One woman had a dream. She had a vision. Her name is Jill Kingston. She's our executive director. She was given my name by a couple people, and she called me 3 different times until I said, sure, I'll come see Lily's Place with you. And I often wonder what I was thinking when I got in a van with a bunch of people that I didn't know and just went to West Virginia, and nobody had referred them to me. It was just a phone call. So she recruited interested people, and she didn't stop until she got the ones that she wanted, which is fabulous. 3 years later, we're opening on the 27th and ready to take babies. She's working to change state and federal law, and she is a force to be reckoned with, and just don't ever tell her no. She refuses to take that for an answer. And this is what it's all about. Keeping our moms and babies together, our families and babies together, and providing the care, in my opinion, for the babies that sets them up to soar to new heights. And that's my son making a PR at 14 feet pole vaulting. So that was his new height. Thank you very much.
Well, thank you all for the work that you all do, putting into practice every day what things we've been talking about today. Appreciate that. we do have some time for questions, and I can kick one off. I'd like to hear some of your thoughts on what you might need to adequately meet the demand. And Margot, I know you and I have talked about this a few times, but what else do you need, say, from a policy standpoint, from a funding standpoint, from a regulatory standpoint, from a community standpoint that would help you meet the need?
That's a really loaded question.
That's what I do for a living.
Right, I know. I should know that.
And I think I can give you this.
Okay, well, you know, I really don't know even how to begin talking about that, you know. There are just so many changes that need to be made. We're dealing with some very antiquated rules and regulations on the federal level, and I know there's been some discussion as far as changing how many clients can be in a building in order to receive Medicaid. That's been a major issue at this time. For residential programs such as ours, we still have limitations of only being able to have 16 women in a building if we're going to build Medicaid. So that's one particular change that needs to happen very, very quickly. We can't have women on a waiting list, because if you can't get them in when they call, you lose them, and often those clients die. So that's one issue.
That issue is the same as well. And I think that having care specific to pregnant women is essential. I think that if we, because they are a subgroup, I think that we need to keep them and realize that, because there are special needs that need to be addressed for pregnant women that are different from men or different than women that are not pregnant. So we need to keep that in the forefront and keep going forward with that, and just keep looking at that from all different angles. I don't know if I can come up with a specific thing right now. I mean, there's just so many different aspects, but just making sure that that stays on the forefront, and that this community and this region keeps identifying that, keeps doing things like this, keeps just doing more educational pieces. Something I wanted to address is earlier that was mentioned about the way that the public, as far as patients that are women, I should say, that are going to the methadone clinic. At St. Elizabeth, we've taken that very seriously, and we are educating our nurses on, decreasing the stigma for women that are coming into the hospital that are on medication-assisted treatment, be that methadone, buprenorphine, whatever that is. And that is something St. Elizabeth is taking very seriously. Our labor and delivery nurses go through classes for that. So I think that going forward, we need to continue that and help the community to realize that this is a disease, and that we treat everyone as a human being, and not treat them less than a human being should be treated.
I think the biggest barrier we're coming up against at the moment is money. It's always about money, isn't it? And I was told that nursing care for these babies is not reimbursable. And I'm curious as to why nursing care would not be reimbursable when it's the primary care that we're giving these babies. And we have good research that shows that that is the kind of care these babies need. Why do we need to give them an escalation of care and care from them in a place, a level 3 NICU, if they are stable and don't need to be there, because some do. But for the babies that don't need to be cared for in a level 3 NICU, why are we not reimbursing for the evidence-based level of care that they actually require, instead of inflating the level of care we're providing them so we can get paid to care for them? To me, that needs to change first.
So are you talking about Medicaid, private insurance, or all of the above?
All of the above.
Margot, the 16-bed rule, I heard through some of my reading that the President's emergency declaration may change that or has the potential to change that. Is that your understanding?
That's my understanding, but, and I may not have all the facts right, and I know Joe Gay is in the audience, and he keeps his eye on the federal regulations and so forth. But I think there's some restrictions as to how many days a client can stay in treatment if we will go over the 16-bed limit. There's a 15-day restriction along that line. And there's some other things rather than just opening up the access for clients going into treatment. So I don't think it's where it needs to be. There's discussion, better discussion on the federal level, but there's still room for improvement in that. Okay. Because basically what they're saying is that the budget is to be neutral. There's no increase in the ability to pay for the services if you expand the number of people in your program, and I don't see how you could do both at the same time.
Okay. So that's still a work in progress?
Yes.
Okay.
Also, could I add one thing, and I can't believe I forgot this, but when I was explaining the programs and the houses at First Step Home, we do have a specialized program called the Terry Shainling Home for Mothers and Infants. And it's an 8-bed home where each woman has her own bedroom. That went online in, I believe, March or May of this past year. And we're partnering with Good Sam Hospital Children's to make sure that we're providing the best wraparound services for the clients there. And we're working very closely with Jobs and Family as well. The women share the common space of the living room and bathrooms and so forth, creating a community for folks that are going through the same things.
It's encouraging to see you all working with other partners in the community and creating partnerships. Do you feel a collaboration like this that we're working on today with research universities and research organizations has potential to make a difference in this problem?
I do. I think that anytime you get a group of people together in a room and you talk about an issue, I think that you're going to come out of it on the other end better. Because if you bring the issues to the forefront, I feel like that someone's going to hear something that they didn't know. So maybe, just as an example, someone didn't know about Baby Steps program, and then when they leave here today, they have a family member or a friend, or they're at work and they know of a pregnant mom, and they're like, oh wait, I remember that Baby Steps program, and they know who to reach out to. So I feel like getting together on any level, I think that is the best way to start the talk and to get the ball rolling to go forward with any topic. And like you said, I had one thing, the gentleman over there asked before about if we track our, our statistics and our research. Yes, we do. Our program has grant funding, so we have to submit every month to the state, and we track how many referrals we have, how many are prenatal referrals, postnatal, how many women we've assisted to treatment, residential treatment, or if they're in transitional, if we help them to transitional housing, wraparound services, if they're going to 12-step meetings. We do actually I lead a 12-step meeting at the St. Elizabeth Journey Recovery Center 1 day a week. So things like that, all of that is submitted to the state. So we do that's why the clerical support will be great when we get that, because we're doing that now. Oh, yeah, I'm sorry.
I need to give a shout out to the Ohio Children's Hospital Association and the Ohio Perinatal Quality Collaborative. For a number of years ago, I can't even remember how long, we got a grant to work on neonatal abstinence syndrome, and all of the children's hospitals in the state got together. And, you know, initially it was kind of a little competitive, I mean, because it always is. But by the time we brought our work to the Ohio Perinatal Quality Collaborative and got the research to the application process, it was within a couple years instead of the 17 to 20 that we so often see. So in my opinion and in my experience, a collaborative like this is how you move the bar in rapid fashion. And I've seen in the state of Ohio, since the OPQC came into being, much less competition, much more collaboration and cooperation. And from there, I got a share seamlessly, steal shamelessly attitude, which is absolutely fantastic. I have no patent on anything. Whatever I do, I want it to go to the greater good. Everybody doesn't feel that way, but I can see that's how you shift a cultural paradigm.
I think when you talk about culture change and shifts and so forth, you have to have an honest conversation as to what's happening in your shop. And this is one of the first forums that I've ever attended where there's been an honest conversation about really what we know about this. You know, it was very enlightening for me just to hear about the name change, and I appreciate that. I know one of the presenters brought that up, so it's always helpful to come to forums like this if there's honest conversation.
I wonder if you could talk for a minute about the demand that you see in your, and I know a couple of the programs are new, but the demand that you're seeing versus the capacity that you have to meet that demand at this point.
What I can say, for years up until probably a few years ago, we had maybe 4 pregnant women a year, and Jean, you can jump on this conversation. And one day we looked at our environment in our residential treatment program, and 15 out of the 16 women we have were pregnant women. We're having more and more pregnant women showing up at our door, late-term pregnancy, that we need to provide services for.
So as of January 1st, we have had 454 referrals to the program. 2 months ago, just for 1 month, had 66 referrals. We get them, like I said, literally 24/7. People reach out to us on our cell phones. And then some of those women, like I mentioned earlier, are referred to residential treatment. Some of them are referred to MAT. And then, of course, some of them we lose contact with. The one thing about our program is that there are some women that will be working with 3 months, 4 months during their pregnancy, doing well. We'll lose contact with them. And then, 2 o'clock in the morning, they'll send a text message and say, I relapsed, I need help, and then we'll just re-engage with them. So we see that often, that people will reach back out to us and ask for help again, and know that we're there to help them.
So before opening, we're getting several phone calls a week asking, when are you opening, because we want our baby to go there. We are also getting phone calls for babies that are completely inappropriate to our program, as in we have babies that need long-term care and we have no long-term care facilities or option for home care for the chronically ill baby at home. So tiny little babies with PICCs, with G-tubes, with trachs, with vents, because there just aren't enough nurses to meet the needs. So the demand is there. And our overall gut feeling is we're going to have a waiting list. What is sad is, to me, is that we have 24 beds and we are able to open because of budget with 4. And then as we move forward, as laws get changed, knock on wood, we will be able to expand the number of babies that we take. But I anticipate a waiting list.
Any questions from the audience? Yeah.
How long do you expect the babies to stay in here? Did you say you follow up 3 months, 6 months, 9 months?
Yes. My expectation is they'll be leaving well before 3 months. We're expecting about 2 weeks length of stay.
Anyone else?
Thank you. So between June 20th of 2016 and March 27th this year, we've had 53 women who delivered babies. There were probably some that were still pregnant before that. But, and I also wanted to let you know the slide has been corrected thanks to my helper here. So when you get the slides through the, that are sent out, it will be correct. Okay.
Any other questions?
I totally forgot to mention that. So our staffing right now is an all RN staff. We want 2 RNs in the building at all times. So the goal is to have a caregiver per baby. So how does that look? Opening with 4 babies, we'll have 2 RNs, and then we have loads of volunteers, like numbering in the hundreds, that want to come in and be cuddlers and rockers. If a mom is there, then the volunteers won't need to be. The nurses, of course, will. But it'll be 2 RNs to 4 babies, so 2-to-1 staff to patient ratio. When we open a second pod, we'd still have 2 RNs, and then we would have a patient care assistant, STNA, in with the nurse in that pod. So it would still be a 2-to-1 patient ratio. If there were 6 babies in a pod, there'd be 2 PCAs and 1 RN. So at a minimum, 2 RNs in the building. Right now, it's all RN staffing until we have more patients. Yes, the physicians round, neonatologists round daily during the week. I actually will be rounding there on the weekends with a physician backup. And I have a number of other neonatal nurse practitioners that are interested in rounding, but I have control issues. So in the beginning, I'm going to do the weekends because I want it to go the way I want it to go. I mean, I want it to meet my vision. I want to make sure that the nurses are doing what we want done. We want everything to be consistent because we know consistency is key. We want our Finnegan scoring to be consistent. There will be inter-observer reliability. And that's the military in me. There is a way it will be done, and I will ensure that.
Other questions?
So how is everybody else using volunteers?
How is everyone else using volunteers?
Right, so how are you using volunteers in your program to supplement what you do? Because, you know, you guys are the most expensive part of providing care to people.
Our program, we don't have volunteers. It's myself, Andrea, and the community health nurse. It's the 3 of us.
We have volunteers that come in and provide different things, but we also have peer mentors, but those are paid positions. So we try to involve the community as much as we can, because a client may hear something from us, paid staff, they may hear the exact thing from someone coming from the community, and may be more apt to hear it than they would from us.
Anyone else? All right. Thank you all. Appreciate it.
Thank you.
Thank you, Dave and panel. It's great to have a media person involved in this topic, and so we thank you, Dave, for your involvement and for your leadership. So we are coming to our goal. We had 2 goals today. One was to learn a lot about neonatal abstinence syndrome, and we've heard a lot of information. My head's kind of swimming with new ideas and new facts. And our second goal was to think about the idea of this multi-state intercollegiate research consortium. And so our next speaker has some experience building exactly that. So please welcome Dr. Beth Bailey from Eastern Tennessee State University. Oh. Do you want to stand here or do you want to? Okay, great. Sure.
All right. Can you hear me okay? Is it on? No. Better? Just need to be closer to my mouth. Thank you. All right, well, good afternoon, everybody. Final talk of the day, so thank you to all of you who have hung in there to hear the conclusion of the day. I was asked to come and share about our, there we go, about our research collaborative. So in Northeast Tennessee, which is where all of this started, we have pulled together a multidisciplinary, multi-state group of people who have come together around the issue of neonatal abstinence syndrome, most specifically, but more generally, opioid use during pregnancy and both the upstream and downstream from that. So that's what I'm going to share with you here today. All right, so much like what you experienced here around 2010, 2011, in Tennessee, we realized we had a problem. So the opioid use was really expanding. We had NAS babies that were flooding our NICUs, and we were trying to figure out what to do. So we had really two groups of people that kind of came together around the issue. We had our health systems who were really struggling with what do we do with these babies. We don't have the resources, we don't have the training, we don't have the evidence-based information, and so a lot of the health systems in the eastern part of Tennessee, which is the Appalachian region where we've seen most of this happen, came together and started talking, which was really the first step. And then in conjunction, we had our Tennessee Department of Health started working to address the strain on Medicaid, because we were seeing this largely as a problem with, at least initially, with our women who were in the Medicaid system. And we didn't have data. So we knew we had a problem, but we didn't know how extensive the problem was. We didn't know where the problem was. We didn't really know what kind of the drivers were of the problem. So the two groups really connected in 2012. And from this came several things, but the two most important, one that you heard about already earlier today was our NAS surveillance system. So Tennessee was the first in the nation. I understand it's grown and a lot of states have it now, but really the first to figure out how big is the problem? How many babies do we have? And so it became a reportable condition in Tennessee. And so we started to collect data. And so that was really the initial contribution of the Tennessee Department of Health to really get us kind of a grip on which counties are we dealing with here. The other thing was that we had several work groups that started to come together around the state to start talking about the issue. So these were people from all different types of domains. We had healthcare workers, we had community service workers, we had researchers, and really all kind of came together to talk about the issues. All right, so the work groups were really focused on care and resources, which was where we needed to be at the beginning of the problem. Unfortunately, though, they were kind of fragmented across our region, and they were duplicating efforts. So we had a group in Northeast Tennessee that was really doing the same thing as the group down in Chattanooga. And so it was kind of fragmented, and we were trying to figure out how to bring this all together. The other thing the groups were really kind of zeroed in on was this whole idea for the need for evidence-based medicine, and you've heard, or evidence-based information. And you've heard this over and over throughout the day about how much we don't know. Well, 5 years ago, we knew even less than we know now. And so we were really struggling, our groups were struggling with, we want to make some good decisions and choices, but we don't have the evidence. Unfortunately, most of these groups, though, were not focused on doing research. They wanted to talk about care, they wanted to talk about increasing resources, all very important issues to talk about, but every time the groups got together, they would talk about, we don't have any evidence, and then that would be the end of the discussion. They weren't really talking about what can we do in terms of generating the research. So there were kind of vocal members in all of these groups that kept saying, well, hey, we should be doing the research. We've got the babies, the problem's here, we've got the people in the room, but we need to start doing the research. And so kind of from this, we had these small core groups of people who were interested in doing research that kind of splintered off from some of these more community-based work groups. We kind of spearheaded this in Northeast Tennessee, mostly because we were the site most closely aligned with the university that had a medical school. So we kind of had some of the resources in place already. We had the mindset around the research. So as we started to kind of meet and get together and figure out how to do this, we had a core group of researchers. We had research-aligned clinicians that started meeting regularly. And then we realized it's bigger than just East Tennessee. So we had gotten together the groups from Knoxville and Chattanooga and the Northeast. But as we started talking, we realized right over the mountain in western North Carolina, there's a big problem too. And when we go up into Southwest Virginia. And so we started reaching out to the other regions to see if we could find other people who were interested in the issue, but specifically interested in doing research. All right, so our regional NAS research work group was what we initially called ourselves. And we met 2 times a month, which is kind of ambitious for getting a group of very busy people together. But a lot of us who'd participated in these kind of things before really felt that a once-a-month meeting doesn't move you forward very quickly. You know, you get in there, you just kind of get reacquainted again, and we get some action items, and then everybody goes their own ways, and then you don't think about it for a while. So when we were meeting twice a month, there was quite a bit of movement fairly quickly. Really important to have a regular time, regular place, so it was on people's schedules, on people's radar. All right, as you can imagine, as we started to expand over 100, 200-mile radius from where we were, we needed a way for people to connect. Everybody couldn't get there every time, so we made sure we had remote in options available. We were always on the lookout for additional interested parties. People would, after a while, see me coming, yes, I know, I'll come to your work group. Because we got really annoying with people because we said, look, you're talking about the problem, let's all be part of the solution. So we really worked on recruiting people. All right, another thing that was really important to our initial success was having a dedicated person to organize that. So it's great, you get faculty level people who are interested, or you've got community clinicians. Great, but do they have time to send out the email reminders for the meeting and to pull together the agenda and to make the phone calls? Okay. So we were very fortunate in Washington County, Tennessee, which is where the university is. We had a local foundation, heard about our work, and came forward with money. And so they said, here's $20,000, can you hire a part-time research assistant with that? I said, absolutely. So we put that money into place, and we made sure that we had a person who was really kind of the point of contact for the group. So we looked to see, you know, how could we get the word out? We got her face out, we brought her into all the meetings, here's who you need to call. So it was really, really quite helpful to have that. All right, in addition, so our meetings. So as we started meeting and looking at what we needed to do, became really important, obviously, first of all, for everybody to get to know each other. So finding out that their person 100 miles up the road was struggling with the same issue you were, was trying to do the same project, really very important to help get those collaborations going. One of the other things we did in our early meetings was we talked about the published research. So we had almost like journal club style situations where somebody would come in and would talk about papers that had recently been published on the issue. So we wanted to make sure that what we were doing was kind of in line with what other people in the field thought needed to be done. We were real careful to catalog what we were doing, what we do and we don't know. So we kept generating, as we were talking, a kind of a wish list of this is the research we want to do. And then finally, we developed a database that really looked, I guess the best way to put it would be the interests of the team members. So we've got everybody listed, and it has what they're interested in doing, the type of research they would like to do, or are available to collaborate on. All right, so as I said, these collaborations were really important, really helped us hook people up that were doing the same thing, but or were interested in doing the same thing. Funding. So funding's a big deal, right? In order to do this stuff, we need money. A lot of the projects that were being done at that point were kind of being done on people's own time, trying to find a way to make it all work. So we started writing grants, and this in and of itself became a bit of a challenge. We had some breakout groups that started working on writing grants. And so I guess it's been about a year now, that we put in a very ambitious NIH R01. So for those of you who are not academics, this is like kind of the biggest funding you can go for individual projects. And we were excited because we got scored. We didn't get funded, but that was the first step. So we're working on that. We put in applications to the March Dimes, Patient-Centered Outcomes Research Institute. We've not hit yet with a big one, but we are hopeful. We've been able to renew our local foundation funding so that we can keep our research assistant going. And then we've secured some other smaller amounts of grant funding. So we've gotten some more regional foundation funding. We've also been able to get some university pots of money, health systems, state health departments have given us money for different projects. So we've scaled back a little bit. We now meet once a month. And what we do now is we do more of this, we talk about the current project. So someone will come and will give a 15-minute talk on the current project that they're doing. And this has been a really good opportunity for brainstorming. So I sit there in these meetings and I look around, and these are some of the smartest people I know, and they've got great ideas. They're all focused on the same topic. And so I'll come in and I'll say, look, here's what I'm working on, here's a challenge. And you've got 20 voices in the room that can help give you ideas. And so that, for me, and a lot of the researchers have been very useful. Let's see what else. So we've developed presentations based on kind of a synthesis of research. So we've kind of moved toward trying to interpret a lot of what's out there. And we do some invited experts as speakers. So this has been really useful because it's kind of increased our visibility in the community. I'll tell you just a little quick story. We had an invited speaker in from the University of Tennessee. So he'd actually been part of our work group off and on. And he is an obstetrician and is doing work on MAT and pregnancy, and had just published a paper on weaning off of MAT during pregnancy. So this is a really controversial, hot topic right now. And so we had a lot of people flock to come hear him. And we ended up with about 150 people in the room. We had to keep changing venues as people were RSVPing. But it was really nice because that we were kind of able to pitch our group, and we really increased our membership after people came in to hear him talk. All right, so our work group itself draws from 5 states, actually 6 states now. We now have 4 members from South Carolina that joined us at our last meeting. So Clemson University and the Greenville, South Carolina Health System are now on board. I have 3 and then 5 in parentheses because really our most active regular attendees are from our 3 core states, which is Tennessee, North Carolina, and Virginia. We have probably, well, let's see, I asked the question, I think it was 124 members that are on our email list that have come at least to some of our functions. At any given meeting, we have about 40 or 50 people in the room. So we have a decent turnout usually for our monthly meetings. I co-chair the work group with our academic chair for pediatrics at ETSU. He's also the CEO of our local children's hospital, so that also helps in terms of resources. And here's just kind of a list of the people who make up our group. Physicians are pretty well represented there, but a lot of specialties because this really encompasses a lot of areas of medicine. Let's see, other health professionals, so we have a lot of nurses, both advanced practice nurses and baccalaureate trained nurses, therapists. I bet we have half a dozen pediatric physical therapists that are part of our group, speech and language pathology, psychology, social work. Some additional disciplines, so I'm a developmental psychologist, so I tend to heavily recruit. We have several of those. Education. So I've heard people talk today about the need to involve early education services or even elementary education services. So we have quite a few early child ed specialists, both from the academic community as well as from the local education community. So we've got Head Start directors that are part of our group. Public health is also well represented. Community service leaders. So when we started doing this, our tendency as academics tends to be reaching out to other academics, right? And so we really wanted to make sure we were engaging the community. And we have several social service agencies in the region that are involved with our group. And it's been really nice to have that kind of voice in the room to give us a little bit of a different perspective that some of us may not hear too often. So this is everything from protective services. We have other agencies that are running programs, much like the ones we just heard about here. And it's been not only helpful for us as researchers, peer researchers, I guess, to hear that voice, but also we've really been able to help them. One of the things you heard here was evaluating their programs. And so we've got the resources among our group to help them start work to evaluate their programs. All right, students. So the one advantage of being part of an academic community is you often have a big pool of students. Student volunteers, student workers, they have been absolutely key to our success because they can do a lot of the legwork, run a lot of the small studies, and provide that manpower. We have a good mix of peer researchers with strong scholarly track records, which is important if you want to get those grants. And clinicians with really more of an interest in research as part of their clinical work. Okay, last two. So these were people who have joined us in the last couple years. We realized how important it was to involve hospital and health systems administrators in this work, and as well as grant writers. They've been key to kind of giving us access to a lot of stuff. And then finally, health system IT specialists. And I'll talk about this on the next couple slides here, but it's been really important to have people in the room that understand the data that's available to us. All right, so as we started trying to look at the data, and we had the data from the surveillance from Tennessee, from the health department, but that's about all we had. And so we were asking these questions, and we didn't even really know what was feasible or possible. So from this, we kind of had this epiphany moment at one of our meetings where we said, well, a lot of us are from health systems. We have electronic health records that give us all of this information. Why aren't we using that? And so from that came what we've called our database project. And so the initial step was to do kind of electronic abstraction to ask our health system administrators to kind of give us a data dump. And so we got these Excel files that had all of the babies that had prenatal opioid exposure and those who were diagnosed with NAS. We got 5 years of data from several different health systems that we started to merge together. Provided really important basic numbers and data, and we did develop a couple of presentations and papers from this, but we realized very quickly what we didn't know and what we couldn't get from that type of abstraction. So our systems learned to work together. I remember several meetings that I thought the detail in my head was just going to explode, but I had IT people from different health systems talking about the coding that goes on behind the electronic health record, which was way beyond me, but there were people in the room who were experts in that, and that was great. So the data that we had really wasn't detailed enough to meet all of our needs. So as you can imagine, electronic health records designed for billing and clinical purposes, not so much for research. And so we realized fairly quickly that we didn't have everything that we needed. So what we've done now is we've gone into doing detailed chart reviews. So this is where the students have been really key. So I have a good cadre of medical students and graduate students in public health and psychology that come in and they sit down and they pour through the medical charts to give us the more detailed information that we're hoping for. And so we have, at this point, reviewed all the NAS cases in 2 of our 3 health systems. And now we're expanding out to those with prenatal opioid exposure that didn't develop NAS, and then we're going to have a matched control group. So we're going to have a good set of data here that we can start to answer some of the questions. All right, so we're all eager. We were very excited when the data started coming in. So we started looking at what questions can we answer, perhaps, with the data that we already have. So one of the things that we've looked at so far has been this idea of predicting how severe NAS will be in babies, because we really don't even know which babies are going to develop NAS a lot of times among all those who are opioid exposed, and certainly the severity. So the data that we have so far has shown, and we've written a paper on this and had I'll have a presentation at the annual tobacco meeting next year, looking at how tobacco and benzodiazepine use in pregnancy impact NAS severity. And so what we found, as a few other studies have also shown, that women who also smoke and use benzodiazepines babies more likely to develop NAS, more likely to have a more severe course of NAS. So that's been kind of critical as we have had our prenatal providers in the room to talk about how that might change care. And so when you have a woman who's on MAT or is using opioids during pregnancy, we need to have a conversation about tobacco and benzodiazepines. All right, some other questions that we've answered from the database. Looking really at the whole polydrug use. So this has kind of been a theme throughout the day, that women who use one substance very often use other substances. And so how does that challenge us when we try to do research? So, I kind of started my career as a pregnancy, alcohol, and cocaine use person in terms of the research. And we knew that women who use cocaine during pregnancy, for example, were using other drugs. But when women got into treatment on MAT, there's kind of this expectation of, we have this drug that has a constrained exposure, we know what the dose is, we know what the timing is, and we tended to kind of view that in isolation. Okay, these women are recovering from an addiction, and so we're very likely going to see other drugs of abuse that turn up in the system. And so we found very much, these women look very much like women who are using illicit drugs in terms of their other risks and their other exposures. So that's going to impact the research. Had one of our medical students, kind of interesting, she pulled out the data on the NAS babies and found that the ones who were born to women who had asthma had a worse course of NAS in the NICU. Don't know what the mechanism might be, but it was kind of an interesting finding. All right, and then we've had quite a few of these, but just to give you a few examples here. So the last one here, looking at how well we're doing at predicting who's exposed. So the one thing we always want to know when a baby comes in, mom gives birth, is this baby exposed to opioids? Do we need to be monitoring for withdrawal? So we think we're doing a good job, but we found, in fact, that the biologic tests that we're using from urine, meconium, cord blood, cord tissue, we were only finding about 70% of those exposed babies. So these were all babies who developed NAS, so we knew they all had exposure, and only about 70% accuracy for any one test. Best was the cord tissue, followed very closely by meconium testing. But what we found is if we combine the data from all the sources, we identified 100%. So, and the one source that was really key that gets a bad rap was self-report. And so if we combine that with the biologic tests, we found that we were identifying all those babies. All right, so quality improvement. So some of the peer researchers in our group said, yeah, quality improvement's important, but is that really our job? So I've really been advocating for quality improvement as a really important piece of research around this topic. One of the things that came out of our database project was coding for NAS and NAS-related issues in the electronic health records. Not incredibly consistent. Dr. Bott is shaking her head. Okay, anybody who does this research knows you try to get into the electronic health records, and all of a sudden, half the babies that you know sat in the NICU going through withdrawal, there's no diagnosis code for NAS. And so we realized if we're ever going to be able to use this data for research purposes, we need to do a better job with coding. So from this has come this whole quality improvement effort in all of our health systems to train our providers to do better coding. Diagnosis criteria, not consistently applied. We've heard this already today. Okay, so we've got Finnegan scores. Is it 2 scores of 12 or more in a row? Is it 3 of 8 or more in a row? We were looking at the babies, and we have all the Finnegan scores in our database. Probably about 20% probably never should have been diagnosed with NAS because they didn't meet the strict criteria. Then we found others that didn't get diagnosed. So it's kind of interesting how poorly we're applying things. So again, this has been a quality improvement effort with our systems. Tagging for longer-term follow-up. So our university practice at East Tennessee State University, our university pediatric practice, is where a lot of these babies go after experiencing NAS in the neonatal period. So this, to me, seemed a perfect place to start looking at long-term follow-up. Unfortunately, we found that about half the babies that had NAS that ended up in our peds practice, there was nothing in the pediatric chart to indicate this baby had gone through withdrawal. Okay, so again, we need to better link that information from the hospital that gets over into pediatric practice. All right, and then we really struggled with this whole idea of real-time information. How am I doing for time? All right. So really wanting to make sure that can we on any given day say how many babies we've had and what that's look like and how are we treating these babies, and we weren't getting that. So we started to develop these dashboards. Actually, Mission Health, our system over in North Carolina, has really led the way in this. And you can call them up and they can tell you as of today how many NAS babies they've had, what percentage have gotten what treatment, how many days they've stayed. So they've really been leading the way on this. All right, so we've had a lot of projects from our group members. Some of them have been a direct result of collaborations within the group. Others have been a little more extraneous to what we're doing. But just to kind of give you an idea here, and really I mention these because much of the work has been a result of this kind of back and forth within our group. So these projects have been ongoing while our group has been meeting, and all of these investigators have come to the group and talked about their projects, solicited other people to collaborate, and have been able to kind of pick everybody's brains about their projects. And I'll have to add another one here. I just got an email this morning from one of our obstetrician maternal fetal medicine physicians that's part of our group, and he just got institutional review board approval to do a study of babies who had NAS and looking at neurodevelopmental outcomes at age 6 months. So that one is moving forward. All right, so one of the questions or one of the discussion points today has been about the research gaps. So as you've heard throughout the day today, there's a lot more that we don't know than what we do know about the topic. And so there's a lot of research questions, and it's kind of interesting that the list that I have developed from feedback from our research group is pretty consistent across the board with what you've heard today in terms of what we see the gaps are. So the long-term health and development of these children, we have almost no data. There's a handful of studies. I was asked to give a talk in North Carolina last week about the long-term effects of prenatal opioid exposure, and they gave me an hour and a half. And I said, there's not enough information to talk for an hour and a half on this topic. So it was kind of interesting. And the neat thing, too, was that was a group of community-based professionals, a lot of home visiting staff, health department, and they were one of the most engaged audiences I've ever had for a research talk. They were so eager to get information about what these kids are going to look like. And so we need to find a way to give it to them. All right, prediction of NAS among exposed newborns. So how do we know? We know only about 1/3 to half of the exposed children develop NAS. Okay, there's a lot of things that lead into this in terms of the dose, timing, type of drug, but a lot of it is very child-specific. Maybe genetics, and maybe that's the way we need to go. Potential impact of postnatal opioid exposure. So this has come up a couple times. Are we making the problem worse by continuing to give opioids after birth? We have no idea. Okay, the impact of other concurrent prenatal exposures, the role of disparities and disadvantage. So this whole idea of polydrug exposure of risk makes it really difficult to look at the pure effect of prenatal opioid exposure because you have all of these other things. So trying to tease that out is going to be really important. But as I told the group in North Carolina last week, we know these kids are at risk. Whether it's the opioids, whether it's the other things going on, this is a high-risk group for developmental problems. All right, diagnosis. We've heard how there's issues around the diagnosis of NAS. Role of non-pharmacologic treatment. It's been very effective, and so we really need some better studies about it. Feasibility, effectiveness of home-based weaning. Okay, so we heard about weaning in a kind of a step-down type of setting. Our health system over in Western North Carolina, 2 of them are sending babies home still being weaned. Okay, and they have some good short-term data, at least, about that effectiveness. And then finally, the whole pregnancy MAT maintenance versus tapering, big issue right now. We really need some better data to inform. All right, so some other, oops, I went backwards here. All right, so We've got some data. We've got a lot of momentum with our group. And so one of the things we've tried to do is advocate for some issues. So I hear a lot of people talking in this room, we need to do this, we need to do that. We need data in order to be able to make those cases. And so where we have the data, we've started to reach out, talk to our legislators, policy people that control the money, trying to figure out how we can leverage those resources. One of the things, again, heard today, universal drug screening prenatally and at delivery, okay? We are still in Tennessee and North Carolina and Virginia. It's a risk assessment model, and so only women that are suspected are getting that testing. So we really need to make that universal. Comprehensive wraparound services in pregnancy. We've heard several examples of that today and how effective those services might be. Developmental follow-up clinics. East Tennessee Children's Hospital in Knoxville's doing a great job with following up with these kids out to age 4, age 5 is what they have. More funding for evidence-based care, right? So what is the evidence? Where we have it, we're really pushing to make sure it's getting funded. More funding for research. Okay, we can't answer the questions until we know, and so making sure that some of that money that's getting poured into the opioid crisis right now goes to really good, high-quality research that's going to inform some of these questions. Okay, and then finally, obviously, quality improvement is going to be important. All right, so last thing here, maintaining and building our team. Just kind of some summary points. A dedicated organizer, as I said, really critical to the effort. Making sure that the time and place work for everybody. We've got video conferencing. It's kind of funny, actually, when you walk into our meetings now, there's a screen. It's kind of like the game show screen where you've got the panels of all the people, and there's these faces all over the screen, and so it's kind of neat to watch as people engage with that. We have a lot of breakout working meetings, so we're working on a grant right now, so we have a core group of people that meet at other times to do that. Always looking for new members and partnerships. We want to make sure that we collaborate on the dissemination of our findings. So too often what happens in research is we get really busy and we spend a lot of time doing the research, but not making sure we disseminate the findings to the people who really need to get them. So not only publishing and going to scientific conferences, but going out to community collaboratives. All right, obviously we're trying to develop larger projects, find resources for that. And then the last bullet point. So this, to me, has kind of been my big thing as we get together, because what can often happen with big collaborative work groups is you get some powerful voices in the room, right? So the CEO of the Children's Hospital is sitting there and has an opinion about something, and then maybe nobody wants to say anything. So we've really tried to make sure that everybody has a seat at the table and everybody has a voice. And so we talk to people from our undergraduate students all the way up to our CEOs to really make sure that everybody feels heard, engaged, and has a voice. And I think probably more than anything, that's been critical to our success. All right. I'm all set. Okay, thank you.
Thank you so much, Dr. Bailey. That's really encouraging for our group to hear somebody that's already done something, and so you can be sure that we're going to keep your email and phone number to be checking in with you. We're at the end of our day, and we're going to invite 4 people up just to give a little reflection on what they heard today and how we might move forward. So you all can start coming up. Lisa Jason, David Wilkerson, Randy Light, and Carla Saunders. If you would just come up here and sit on this stage here, we'll pass the microphone along. And as soon as we get through with this short reflection, then we're going to invite you to a reception next door. And you can stand around and just chat with folks and talk about what you heard today. So what we'd love for you to do is just introduce yourself and where you're from again, and just give a reflection of what you heard today and what you think the possibilities are for this consortium going forward. Do you mind starting? Okay, great.
Hi, I'm Dave Wilkerson. I'm a clinician. I still provide treatment to people, but I'm also a social work educator here at Northern Kentucky University. All I can say is so many opioids, so little time, right? I'm a little concerned that the researcher folks, especially the medical researchers, haven't figured this out yet. It's somewhat disconcerting to know how much we don't know about NAS. So that's one takeaway for me, that we don't know a lot. There's conflicting, even conflicting diagnostic criteria for the disorder. And then the particular takeaway for me is the variance among the medication-assisted treatment used for the newborns. So this was important for me to hear and was educational for me. Then additionally, I liked the fact that some of the biological researchers also included the notion of protective factors, working with the family, working with this infant isn't going to continue in a vacuum in the world, and much of what I see in practice treating people are the casualties of these kids growing up. The father, what role does that individual have with the child, but also with the other agencies involved with the mother? And then finally, I just think that the degree to which we can decriminalize the notion of addiction is the degree to which we'll get closer to answering, I think, a lot of these questions.
Thank you.
Thank you. I'm Randy Leidy. I'm Dean of the College of Health Sciences and Professions at Ohio University. And we're really, this is really our first contact with the consortium. Actually, Sam Quinones, when he was at our campus, informed us of this and suggested we come. So we're thrilled to be here today. And I guess my takeaways from the day, you know, I think the biggest takeaway was the first question that you asked of the panel. Did anyone remember what that first question was of the panel, the first panel of the afternoon? Oh my gosh, you've missed the key point of the whole day, people. It was, can you all tell us what research would be helpful to you? And I think that really hits the nail on the head. How many of you in here are researchers? Okay, only a few. And how many of you are practitioners, clinicians, professionals? Okay. So here's the problem. Here's our great failure as higher education. Everything we do in two ways that are exactly wrong. We go out and say to all of you people, here's what we do, come and get it if you want it. And the second thing we do, I shouldn't have brought this up here with me, we go out with our hand out. Yeah, we'll do some stuff for you if you pay us, okay? So for this stuff to work, you made the point, why don't the medical researchers get it? For this stuff to work, I mean, this day, in my mind, is really about the future in terms of what we do in higher education. You know, and we've got Dr. Bailey talking about a great consortium. Actually, we're going to be down on her campus in a few weeks talking about collaboration down there. This consortium starting, we've been working on an Ohio-wide consortium around issues. And I think the more of this we can do, the more effective we'll be. I'll go back to Sam Quinones. I'll just channel him a bit. He left, but he mentioned the space program and going to the moon. Now, if you looked at the Apollo spacecraft that landed on the moon, I was a geek when I was a kid. I wanted to be an astronaut. If you looked at the Apollo spacecraft and the men who were in it and all the people who supported it, that stuff happened because there were thousands of places around this nation doing research to support the space program. And if you buy his argument that this opioid stuff rises to that level of national issue, those 1,000 places didn't research in their own silos. They came together. They didn't do the research they wanted to do. They did the research that the government told them needed done. And I really think that's the approach. And the exciting thing about a consortium like this, I think, is activities like this where we can come together, we can talk, we can take away knowledge from people who we don't encounter every day and go back and do our jobs better and then come back together and advance everything forward. So just some thoughts as I listened all day.
Thank you very much.
I'm Lisa Jason. I'm a neonatal nurse practitioner, and As a doctor of nursing practice, I feel like my role is implementation. So in a word, I'm an implementer. I feel like the job of the DNP as a clinical doctor is to take the evidence and then apply it into practice and truly decrease that time from knowing that something works and having a body of evidence that shows it to work and getting it to the bedside. So really, this morning as I listened, I kept looking at Katie Carey, who works with me at Bridgets Path, and going, that's why we're doing what we're doing. That's why we're doing what we're doing. See, wraparound services. That's why we're doing what we're doing. And I think gathering the outcomes from those of us that are implementing, all of the clinicians that are implementing the programs, is going to be just as important as the initial research, because the research that we're going shows it works in that that laboratory environment, if you will. But then when we're applying it at the bedside, applying it in the clinical setting, it shows that it works in the down and dirty with the staffing that you have, in the environment that you have, sometimes across cultures of hospitals, sometimes not. But I think we need to complete that full circle and make sure we not only have researchers involved in the collaborative, but quality improvement and evidence-based implementers, and then outcome gatherers, and then come back around and close that loop of outcomes to ensure that A, we're using the evidence correctly, B, we're collecting outcomes and not just forgetting about it once we implement it, and C, that we're coming back to say, okay, this worked in this environment, but it didn't work in this. Let's drop back and punt and see what the next iteration of this is.
Thank you, Lisa.
Hi, I'm Carla Saunders again, and also neonatal nurse practitioner, and I think we're summarizing the day. I apologize, I was on the call. Everybody has really hit on the highlights, I would say. I think going across the country and speaking in forums like this and seeing people gathering and struggling with the same issues at various points. So I see that everybody goes through this evolutionary process as the problem starts to hit and starts to really overtake your unit or overtake your community. And there's so much interest that comes to the table, and I think part of it is because the babies are the tail of the tiger for the problem. But there's a lot of work that has been done, that's in process of being done, and agreed 100%. This is one of those times that we need good prospective research, but we also need to be able to do very quick quality improvement type work at the ground level because we're drowning. But what I see is that in the idea of true collaboration, this is a time when we really need a national effort. We need, and I love what you were saying to elaborate on Sam's point, and that is people weren't just doing what they thought needed to be done. It was organized. And I think that is where we can make our greatest gains, is if there would be a way to have a national type research database for this, where people who have interest in certain areas or are already doing work in certain areas, we could have that piece, and then bring that information back and try and synthesize that. And I think in that manner too, we could get, we would really be kind of forced to come through with some standardized definitions that we're still struggling with. And you may have one in your consortium, or you may have one in your state, but those may not be the same from state to state. So again, our research then is dependent upon what your definitions are. So before, it's such exhausting work, really. It's rejuvenating, but it's exhausting. But I think a way to really improve upon that is to have some sort of national collective that we can look at this from, where groups such as this can then take a regional perspective and put their thoughts and their findings into it.
Thank you, Carla. Let's thank the panel here for their reflections. And I'm going to turn it back over to Provost Rowlands to give us our final benediction for today.
I just want to thank again every single person who presented today and gave us the benefit of their experience, their research, their lived and translational work that they're doing, and I really appreciate all of you being here. And then I appreciate so much all of you who have participated by attending. And I know it's late on a Friday. There really is wine and cheese, and I assume some crackers and next door, and I would just encourage you to take a few more minutes, stick around just a few more minutes, and thank you so much to Sam and Mark and Gail and everyone who has worked so hard to organize this conference. So thank you for being here. Thank you all for your work. We'll keep doing it. We don't know what's next, but something will be next. So thank you.